I am Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning carotid interventions. With MoMA device, make sure you don't overinflate the balloon. So how do you know when the inflation is sufficient enough? So once the balloon loses its circularity and it becomes rectangular in shape, that means now it's expanding along the vessel walls. So now you don't need to further inflate the balloon. It has already occluded the vessel. So if you get dissections like these with overinflation of external carotid artery balloons, these are non-flow limiting dissections and we don't bother for it. You don't need to intervene for it. In any case, external carotid artery gives branches to the face, and face has extensive bilateral supply. So if the other side external carotid artery is patent, then during intervention, even if the external carotid artery gets occluded, we don't bother much about it. We don't chase it. So the main problem with MoMA device is when you have a 100% occlusion of the contralateral side, because then it's an issue of tolerability if the patient will tolerate the occlusion on this side, because the other side is already 100% occluded. So there are ways of doing that, but relatively contraindicated. But if you've got disease pattern like this, where you have external carotid artery osteal disease, here you can see external carotid artery osteal disease, here you can see third case external carotid artery osteal disease. So what to do in these cases? Can we safely use MoMA device in them? Well, it's an expensive device, and before you open this device, you need to make sure that it will go through this external carotid artery if you want to use it. So the way to do it is you first take a Teromo wire 035, cross it into the external carotid artery there, and then take a 4 or 5 French diagnostic catheter over it. If it goes across, that means the MoMA device will also go across. So then you can change it over an implant super stiff wire and bring your MoMA device in, and the external carotid artery balloon will easily go across this, and you can inflate the balloon here. In these three cases, you can see the balloon inflated here, the balloon is inflated here, and the balloon is inflated here. So in all three cases, we were able to cross this. With filter, always remember, if there is a no flow, no reflow type situation, always think that your filter is choked due to distal embolization. Usually happens after pre-dilatation or post-dilatation. So never remove the filter or capture the filter when it is filled with thrombotic material. You've got to first empty the filter and only then retrieve it. Otherwise, while capturing it, the material will embolize and go into the cerebral circulation and cause stroke. At times, the capturing system, the retrieval system device that you take in to capture the filter, it gets stuck on the lower border of the stent and does not go into the stent to come across. So for that, what you need to do is try to change the directions of the head. By changing the direction of the head, the shape of the carotid changes and you may easily take it across the stent. The other thing could be ask the patient to flex the neck and touch the chin to the sternum. Again, it may change the angulation in a way that the retrieval device goes into the stent easily. Otherwise, you can even try to take a 5 French multi-purpose 125 centimeter long diagnostic catheter and use that to go and capture the filter. You can use a guide liner to do that. And if on the way back the filter is partially captured and gets stuck onto the distal end of the carotid stent, then don't pull it any further. Leave it at that, take a balloon in and push the filter back into the internal carotid artery so that it gets released from behind the stent struts, and then recapture it completely and then take it through the stent. If your system is not going, your capturing system or retrieval system is not going into the stent, despite of all the maneuvers, what you can do is inflate a 5 millimeter balloon in the stent or a 4 millimeter balloon in the stent, and push your guide over it into the stent, and that will straighten the stent, and now you can remove the balloon and take your filter retrieval device through the stent. So in carotid tortuosities, it's better to use proximal protection device to avoid this filter issue, because these issues you mostly face in the tortuous anatomies. You can get variants resulting from elongation of internal carotid arteries which have kinks, loops or coils. In these you need to be careful while placing your device. Now you can see here in this case there is not only, this is the critical ICA disease. Here you can see that there is a bad bend over here, and then in the other view if you see there is a big loop over here. Now the problem with this loop was that the filter device was hard to push through, and the concern was that even if we get it through, then it will be difficult to take the retrieval device through it. So what was done here, the filter was deployed just in the beginning of the loop here. It's touching the walls of the carotid artery on both sides, and then the stent was taken in, and you can see the stent being deployed here. Now in this case, if there is a difficulty to take the stent because there is a big angulation there, you can use a guide liner. You can take your guide up or use a guide liner. And there was another case in which even Sophia Plus was used, which is an aspiration, 6 French aspiration catheter for the stroke patients. So that's pre-intervention, and you can see how this whole bend is straightened up. What's important is that never end the stent in a bend or kink. That's the same as being done in coronaries. You don't end your stent in a bend or a kink. You can even buddy wire with the distal filter if required. So you can do maneuvers to do it. Now in this case, a 6 French Sophia Plus was used to deliver the stent because the stent would not take this bend. So first a 6 French Sophia Plus was taken across, and it was used as a guide liner, and then the stent was delivered across, and you can see the stent result here. Now if you have thrombus sitting here, it is right at the bifurcation involving the ostium of the internal carotid artery and the ostium of the external carotid artery. What type of protection device can we use here? If we take a distal filter, high probability you may embolize this material. If you want to take a MoMA device, high probability while going across again you can cause distal embolization. So the best thing in this case would be to use a single balloon tip guide, which can be an 8 French MoMA. It can be a cello guide from Medtronic, or a Bobby device from Microvention. These are all single balloon tip guides which do not have a body going into the external carotid artery. So you cause proximal flow occlusion, and then you can safely intervene here. And if you have a thrombotic lesion like this, here there is no problem. You can put in an external, you can put in a MoMA device which will have one balloon here in the external carotid, the other balloon in the common carotid, and you can safely then intervene on this. If you have a tandem lesion, that is a lesion in the internal carotid artery and common carotid artery, and you're using a MoMA device for proximal protection, you need to stent the internal carotid artery first, and if the stent does not cover the common carotid artery disease, then you've got to take another stent. So now you'll have to deflate the balloon of the external carotid artery and the common carotid artery and pull your guide catheter MoMA device down into the common carotid, and now you'll have to use it as a normal guide catheter. Take a distal filter and put it in the internal carotid artery, and then take a second stent and cover the common carotid artery. The other way could be, if you want to avoid the distal filter, then you can use inflate only the common carotid artery balloon of the MoMA device, and then open the O-ring of your Y connector so that the external carotid artery blood goes into the guide catheter and out of the Y connector, rather than it going towards the internal carotid artery and risking distal embolization. So this way you can still use single balloon MoMA to give proximal protection, for tandem lesions. Now, there is also a condition called carotid web. Now, in carotid web, what happens is there is an outpouching in the internal carotid artery like this. So normally you don't bother much about them, but if the patient is getting recurrent TIAs because of this, then it means that the material gets deposited in this pouch, and then it keeps embolizing from here and causes stroke. So the way to manage them is that if you have a carotid web, put the patient on dual antiplatelets indefinitely, and also do fibromuscular dysplasia workup for these patients. If despite of being on dual antiplatelet therapy, the patient becomes symptomatic, gets a TIA or a stroke, then you need to intervene on this patient and you need to either stent this or do an endarterectomy for this patient. Then there is another entity called carotid artery dissection. So it can be post-accidental or iatrogenic after carotid artery stenting. Spontaneous coronary artery dissection may be associated with vascular disorders like fibromuscular dysplasia, Marfan syndrome, collagen vascular disease, homocystinuria, cystic medial necrosis. Traumatic carotid artery dissection may be due to stretching over transverse process or prominent styloid process. Now, the carotid dissections can present either as stenosis, as you can see over here. It can present as aneurysm. It can present as dissection. You can see the dissection flap here. Or it can present as occlusion like this, a pencil tip tapered occlusion. Now, this is a case of a young man with motorcycle accident which led to left internal carotid artery dissection with embolic stroke. You can see it over here. That's the internal carotid and the dissection. This patient had a stroke, and you can see that there is a pseudoaneurysm, there is a false lumen over here, and that's the true lumen. So you need to be careful while wiring this, and then you have to make sure that once you wire it, go up with a microcatheter, take a distal tip injection to make sure that you are in the true lumen. Only if you are in the true lumen, then bring in the bigger hardware in. So you put in a distal filter here, and then the stent is deployed. And what you don't need to do in these patients is to predilate or postdilate, because there is no atherosclerotic stenosis here. You don't need to predilate or postdilate. The stent will expand on its own. So IVUS or microcatheter tip injection to confirm the true lumen, as the deploying a stent in false lumen can be a disaster. So which is more likely to be due to dissection, this type of an occlusion or this type of an occlusion? So it is the pencil tip shape occlusion which is more likely to be because of dissection. Now, if you look at this was a patient where a coronary angiogram was being done, and then they injected, and this is what happened. So you can see ballooning, sudden ballooning with contrast injection of the brachiocephalic and the common carotid. So what's happened is probably injection was given with force while the pressure was already damped or ventricularized, and they did not realize that and gave the injection. So this is iatrogenic catheter-induced brachiocephalic and right common carotid dissection, which stopped just before right common carotid artery bifurcation on CTA. Patient was asymptomatic. So we fully heparinized the patient with PTTK target twice the normal, kept the patient in ICU setting for neuro check every hour, kept the BP on the higher side, 140 to 160 millimeters of mercury, and then we gave patient oral anticoagulation for 3 months. We did not intervene on this patient because he was totally asymptomatic. If they become symptomatic, then this needs to be stented. But in this case, we did not have to, and the patient was kept on medical treatment and did well. This is a 52-year-old gentleman. He presented with acute stroke to another hospital where they found occluded left middle cerebral artery and bilateral ICA dissection. They recanalized the left MC and treated the left internal carotid artery dissection with overlapping Casper stents. The right internal carotid artery dissection was left as such. On follow-up CT angio after 1 month, it was seen that the left internal carotid artery stents were occluded, but the left MCA and ACA were patent as they were being cross-filled through the left PCOM, through the left supraclinoid ICA segment. CT also showed expanding pseudoaneurysm of right internal carotid artery, and therefore it was decided to treat the right internal carotid artery. Now, injection of the posterior circulation done here shows that there is cross-filling of the left supraclinoid ICS segment, that is seen here, and the left middle cerebral artery can be seen here. This is all being cross-filled from the posterior circulation, and that same thing is seen on the left on the lateral view of the posterior circulation. You can see here the basilar artery, and then that's the middle cerebral artery territory being cross-filled through the PCOM. The left internal carotid stents were occluded. These were Casper stents here. You can see the markers that are visible here. These are the markers. These are peculiar markers for the Casper stents. These were totally occluded. And you can see here a dissection flap, white line seen in the left internal carotid artery and the pseudoaneurysm. Now this is the right internal carotid artery, and that's this again the white flap that you can see of the dissection and the pseudoaneurysm. So careful wiring was done, ensuring that the wire goes through the true lumen, and then NAV6 filter was deployed. That's the NAV6 filter which is visible over here. This is deployed. Now that's another Casper stent that has been brought in. This is the check injection, which is nicely showing the white dissection flap and pseudoaneurysm on one side of the stent. So you can see here the white dissection flap seen here, and similarly white dissection flap is seen here. So the stent has been placed, and this is the final result. This is a patient who was symptomatic, brought in for angiography, and you can see here that the right internal carotid artery has a very calcific disease. The external carotid artery is totally occluded, and there is a lot of calcification that you can see over here, right where the disease is. So instead of NAV6, we took spider FX because that can go on any wire. So we used a pilot 200 wire to cross this lesion, and then we deployed the spider FX and pre-dilated with a 4.5 by 18 non-compliant balloon. After that, after pre-dilatation, you can see here that's the result. Decided to go ahead with 8 by 6 into 40 millimeter exact stent, and you can see some effect over here, right here. What's happening here? Is there a dissection? But we thought that nothing aggressive had been done, and this has got to be accordion effect. So we went on to deploy the stent, and then post-dilated the stent with a 4.5 by 18 same pre-dilatation balloon we used for post-dilatation. After stent deployment, this is the result. Again, it can be worrying to see this thing, but in our mind this was accordion effect. So we took the retriever and took the spider FX out, and after that you can see the final result. So it was indeed an accordion effect that was giving a very terrible picture, but with removal of the filter, the whole artery was able to take its bends, which were previously straightened out because of the device presence. Approach is not possible during carotid interventions or stroke interventions. As you can see here in this case, the ultrasound guided femoral puncture was done, but then it was not possible to go beyond. And when we came from the brachial approach and took a picture, you can see here that the abdominal aorta is totally occluded at this point. Now, so this is a brachial approach. So SIM2 catheter can be used in a similar fashion as used from the femoral approach. So the shape is being done in the ascending aorta, and then all you need to do is pull it up and it will go smoothly into the desired artery. Here you can see the left carotid coming off here. So that's the non-culprit in this case, the left internal carotid artery. So first the non-culprit picture is being taken to complete the diagnostic work. So just pulling it up, SIM has gone into the left carotid. You can see here some moderate disease here, nothing much. You take a cerebral angio of the non-culprit side just to see that both the anterior cerebral arteries are being cross-filled. So the right AC has also been cross-filled from the left. So this is one information that you've got here. So then you've gone on to the right side. You can see how the catheter is coming up, and by pulling it up, it's gone into the right common carotid artery. And then you take a picture and you see that there is a critical osteal disease in the culprit right internal carotid artery. Now you are going to exchange the wire, and you've taken the destination sheath that's gone up. SIM2 has been removed. This is an 035 exchange wire, and on top of that, destination sheath has been taken through the brachial approach. This is 6 French 90 centimeters. Fielder XT wire was used here. So here, if you want to make a choice between NAV6 and Spider FX, if you think it might be difficult to cross the wire, then NAV6 would not be a good choice, because you can't change the wire with NAV6 filter. So with Fielder XT, with the Spider FX, the advantage is, now we're coming from the brachial approach, you take a Fielder XT wire that's gone across, and now on top of Fielder XT wire, you can take the Spider FX 7mm delivery system is being taken up. Now once you reach the point where you want to deliver the filter, now you will remove the Fielder XT wire. The delivery system is in position. You can see the marker there where the red dot is, and you've removed the Fielder XT wire, and you start pushing the filter through the delivery system, and once it gets, the distal marker gets aligned with this delivery system marker, then you unsheath the filter and the filter gets deployed as seen here. And now the filter is in position. You take a check injection to make sure that the filter is at a place where it is opposing well to the internal carotid artery walls on all sides, because if it was not opposing well, then material would have embolized and gone across from the sides of the filter. So once that is done, then rest is just the angioplasty. You've done a balloon dilatation here, and then after pre-dilatation, you are deploying a carotid wall stent. This is 7 by 30mm in position. You've deployed half of the stent, and then you are doing a check injection to make sure that the stent is in good position, because otherwise you can still retrieve and reposition this carotid wall stent 7 by 30mm. And now once you're satisfied, you are deploying it fully, and then you have a fully deployed stent. Now you bring in the filter retrieval system, and you are retrieving Spider FX, and that is being retrieved. The whole system is being retrieved. You've done a pre-intervention cerebral angio, and now you do a post-intervention cerebral angio, and you confirm that all the vessels are patent, and you've seen the carotid. Look at this carotid. It had a very unstable looking plaque. This is proximal left internal carotid artery. So we decided not to predilate this. Instead, we placed a Spider FX filter here, and then without predilatation, we deployed a carotid wall stent 9 by 40 and did not post-dilate. But we could see haziness over here. That's the region where the filter is. So we decided to retrieve the filter, but immediately after retrieval, there was no flow in the carotid stent. So you can see here, there is no flow. So when we took the pictures, we saw that the middle cerebral artery had also occluded. So now we've got an occluded ICA and middle cerebral artery. So there was distal embolization. So Sophia Plus from Microvention Teromo, and this is Solitaire from Medtronic stent retriever. So they were taken, and both ICA and MCA were recanalized. And that's the final view. So the lesson learned from this case is that the blocked carotid filter should first be emptied with another thrombus aspiration catheter before retrieving the filter. This will reduce the chances of distal embolization. If you've got a choked filter, you've got to aspirate the filter, empty it first before you actually retrieve the filter. This patient presented with recurrent TIAs. We can see the critical carotid here with some haziness in it. Spider FX was used for distal protection. 5 by 20mm non-compliant balloon was used for pre-dilatation, and that's the Protege carotid stent 8/6 40mm, and that's the final result. So the procedure was uncomplicated, and the patient was fine. He was on dual antiplatelet therapy. His loading was done with clopidogrel and aspirin, 600 milligrams clopi and 300 milligrams of aspirin. As per our routine, post cerebral angiogram was done, and both MCAs and the uh, fetal PCA were patent, whereas the anterior cerebral artery we already knew was being cross-filled from the other side. Now, the next morning, patient had a stroke. His CT was done, CT angio was done as per stroke protocol, and we found that his carotid stent had occluded, so it was stent thrombosis. We brought the patient on the table, and sure enough, the stent was totally occluded. Reviewing our last image, what we could see now was that there was a bit of haziness here within the protege stent, which I did not pick up initially. So this was probably plaque prolapse or a thrombus sitting in the stent. We know that protege stent is an open cell design and has large cell size, and therefore there is a tendency or a potential to have this plaque prolapse. In any case, stroke intervention was planned. Initially, contact aspiration was done, but despite of multiple attempts with Sophia Plus, you can still see a lot of thrombus in the carotid. You can see here, and then you can also see the blocked right middle cerebral artery. So this was also occluded. So after contact aspiration attempts, it was planned to do combined stent retriever and aspiration technique. So that's the lateral image showing the same occluded middle cerebral artery. So then Sulumbra was done. You can see here the stent retriever deployed, and the injection through the aspiration catheter shows flow going across it. And after retrieving the stent retriever and the aspiration device, you can see the cerebral circulation is now patent. The flow has been established in the middle cerebral artery, but there is a lot of thrombus that can still be seen distal to the carotid stent. So now it was planned that despite of the stent retriever and the contact aspirations, this ICA thrombus we were unable to remove. Therefore, we decided to go with two stent strategy, that is parallel stents, two parallel stent retrievers to remove this ICA thrombus. For that, we had to take our guide sheath above the level of the carotid stent in order to avoid entanglement of the stent retrievers during the retrieval process. Therefore, we again took an 035 wire. We tried to safely take the sheath above the stent. It was a little difficult and challenging. Therefore, we used the BAT technique, that is the balloon assisted technique. We used the same 5 by 40 millimeter, 5 by 20 millimeter NC track balloon, and that was taken, and on top of it, this destination sheath was slided over it while the balloon was deflating, and the guide sheath was taken above the level of the carotid stent. You can see here the two tips, the tip of the two micro catheters that are placed in the internal carotid artery, and through these two, the two stent retrievers, Solitaire X 4 by 40 were deployed. Now these stent retrievers are deployed parallel to each other, and the sheath, you can see destination sheath is above the level of the stent. So then the contact aspiration device or Sophia Plus was again taken back up onto the stent retrievers, and then the whole unit was retrieved, making sure that the destination sheath remains above the level of the stent, carotid stent, so that these two stent retrievers do not get entangled. And then the flow was established in the internal carotid artery, but there was still some thrombus visible, resistant thrombus visible in the protege stent, and therefore another wall stent 7 by 30 was deployed within the protege stent, and this is the final result. This is an interesting case. 74-year-old gentleman came in with 6 hours history of left-sided hemiplegia. He was unresponsive, had a pre-stroke MRS of 0, NIHSS was 20, CT brain did not show any intracerebral bleed, aspect score was 7. These were the early days of our stroke program. So CT perfusion was not available to us at that time. We went on with the CT angiogram that showed tandem occlusion with right internal carotid artery and MCA occlusion. This patient was taken onto the cath table. You can see the right internal carotid artery is totally occluded. The stump is probably here or here. You can see two nibs there. So one of these two is the origin of the right internal carotid artery. We took 6 French 90 centimeter Fubuki sheath, Sophia plus 6 French aspiration catheter, pilot 200 wire and 2.5 by 15 balloon. Pilot 200 wire was crossed and then 2.5 15 balloon was used. But Sophia plus, even after aspiration, the view that we got showed that there was significant disease at the ostium of the internal carotid artery and the flow was not good in the internal carotid. So we decided to use a 5 by 20 millimeter NC track balloon through Sophia plus. But once we had done the inflation, we came to know that this balloon could not be retrieved after deflation into the Sophia. So we had to remove both Sophia and the balloon together as one unit. Now this is the picture after the balloon inflation, and what we see is that there is a significant ostial recoil in the internal carotid along with the dissection that is seen. Therefore, we decided to deal with the carotid first and deployed a Casper 8 by 25 millimeter double mesh layer stent. There was a significant waste in the stent for which the same 5 by 20 millimeter balloon now was used through Fubuki sheath. Sophia had been removed. But to our surprise, the balloon could not be withdrawn into the 6 French Fubuki sheath. We, we tried our best, we could not, and as a result, the balloon broke. The shaft broke, and the 5 millimeter balloon, you can see the two markers within the stent over here. So we measured, and the wire position was also lost. We took the shaft out, and then we took a new balloon out, 5 by 20, and measured the length of the balloon, and we came to know that the balloon had broken very close to where this marker is. So there isn't much of a shaft hanging there. It's mainly within the stent. So then we took 014 wire. It was difficult to take across, so we took an 035 wire and then took a Fubuki sheath into the stent over it. And then we decided to deal with the cerebral circulation first, and then we used combined aspiration and stent retriever technique, and we recanalized the MCA. There was still embolization in the ACA, for which we put a microcatheter, Raybar microcatheter into the ACA, and we gave 5 milligrams of intraarterial TPA. And here you can see now that both ACA and MCA are fully recanalized, and then we now had to deal with that trapped balloon in the carotid stent. So we took a snare, we tried to grab the balloon shaft with the snare, but we failed. Then we decided that we will jail this balloon here because there was no other way of taking it out. So we took a carotid wall stent 7 by 30 millimeter and sandwiched this balloon between the two stents, Casper and the wall stent. Here you can see the wall stent being deployed. That's the Casper stent, and here you can see the two markers of the broken balloon. But it did not expand very well. Where the balloon was present, the wall stent did not expand well. So we brought another 5 by 20 millimeter NC track balloon through Fubuki sheath and post-dilated this stent. What we thought was that there was some mistake in our handling the balloon, that the balloon shaft broke over there and it did not come through the Fubuki. We did not realize that it could be a compatibility issue or the softness of the distal tip of the Fubuki, that the 5 millimeter balloon, after losing its shape, it's difficult to bring it in. But in any case, we took our chances. We used this 5 millimeter balloon to post dilate the wall stent, and then now again it was difficult to remove this balloon. This balloon also would not come into the Fubuki, so we had to remove the whole assembly as such with the balloon and the sheath together. And that's the final angiographic image after having removed everything. You can see the filling defect here behind the wall stent and the Casper. The markers, both markers are behind the wall stent, but this filling defect extends beyond the wall stent. So we thought this could be thrombus. So we took the Sophia plus, tried to aspirate this thrombus, but this would not come out. So the next step we did was we did an IVUS study of this carotid stent. And what the IVUS showed to us was this is the wall stent layer, and those that are being marked is the Casper layer stent, and in between is this filling defect that you see here, and this is that partially deflated balloon that you can see here. And you can, on the longitudinal section also, you can see this filling defect there, this blackness. This is that partially deflated balloon or the jailed balloon. Again on DSA, you can see here these red markers are showing the two markers of the balloon, and the yellow is showing the extension of this balloon. Somehow it got deformed and the balloon is slightly pushed upwards beyond the markers. And on the IVUS longitudinal section, you can see this balloon here. 3 days later, the patient had a CTA, and on the CTA, you can see here again, you can see this balloon extending beyond the wall stent layer. So this is the compressed balloon between the two stents. So the take-home message that from this case we can take is that large size balloons like a 5 millimeter balloon should not be used with soft tip catheters like 6 French neuroaspiration catheters or even Fubuki sheath. So now as a policy, when we have to deal with tandem occlusions during stroke, if we know that the carotid is occluded, we do not take a Fubuki sheath. We will either take an 8 French multi-purpose guide catheter, or we will take a 6 French 90 centimeter destination sheath, and we deal with it, or even a balloon tip guide catheter. These are all fine, and even a 5 French balloon can easily be used and brought back, but not with Fubuki sheath or the neuroaspiration catheters. Now, Takayasu arthritis is a difficult vasculitic issue to deal with. I just wanted to show you this case which was shown in one of the conferences from India, where they had to do multiple stentings, and all I want to show you is that despite of repeated attempts with stents, drug-coated balloons, no matter what they did, it kept coming back and back and back with restenosis. And look at the number of times they had to do. Every time the stents would occlude, and they would have to do something again and again. So revascularization procedures should be avoided during the active phase of the disease. Check the CRP. Percutaneous intervention is less likely to be successful when stenosis or occlusions affect lengthy portions of an artery. Long stents are never a good idea. Overlapping stents is never a good idea. Restenosis is less likely when performed after initiation of treatment or when revascularization is followed by anti-inflammatory therapy like steroids, immunosuppressants, and immunomodulators. Now, this is a case of a tandem lesion. What's a tandem lesion? Where you have a stroke with cerebral and carotid involvement. So you can see here, that's the first picture. It's a tapered tip, pencil-like tapered tip. So we know that this could be occlusion here. And after aspiration here, this is what came out. So it's basically atherosclerotic disease here. It's a tight stenosis. You can see some clot over here, and then rest of the circulation is occluded. You can't see anything above this occlusion. So first thing to do, we had to balloon the internal carotid artery to be able to go across. Then we went up after dilatation, and we found that the middle cerebral artery was totally occluded here. So we did Solumbra, that's a solitaire, that stent was deployed here and then it was pulled out along with suction going on, that's Solumbra, and middle cerebral artery was fully recanalized. And when on our way back, we took a shot of the carotid artery, we saw that this was also patent and it was holding well. We waited for 10 minutes, took the injections again, it was still holding well. So then we did not stent the carotid. So what we do is we tend to avoid giving patients antiplatelets during this cerebral intervention for the fear that may convert to hemorrhagic transformation. So if it's holding well, we wait for 48 hours, we keep the patient in-house, and after 48 hours, we will bring the patient back and stent this carotid and put the patient on dual antiplatelet therapy. But if this was not holding well, then we don't have a choice. We will stent this carotid during the stroke intervention. We will give the patient half the coronary bolus dose of agrastat because there is no dual antiplatelet on board at present. And once the procedure finishes, then we will put an NG tube into the patient and give the patient dual antiplatelet loading on the table. And now we mostly do it with ticagrelor or 180 milligrams and disprin 300 milligrams. So that's a risk then you have to take even during stroke intervention. So this is another patient where the carotid is totally occluded. It's a stroke case and it's a total occlusion of carotid, and it was a difficult lesion to cross. It was like a acute on chronic occlusion. And we finally had to use, after different wires, Fielder XT and other coronary wires and the Trexus wire from neurointervention, we finally went on with a Pilot 200 with Raybar microcatheter, and that's the Pilot 200 which finally crossed this lesion. We first went up to make sure we're in the true lumen, did a microcatheter tip injection to confirm the true lumen. Once that was confirmed, then we changed it to a neurointervention wire. And then we did the balloon angioplasty here in the internal carotid so that we can take the hardware up. 3 and 5 millimeter balloons were used. And since it was occluding again and again, so we put in a Casper stent first before we went up. And with this Casper stent, you can see there is still there is still recoil and the stent is not opening up fully over here. So we had to do a 5 millimeter post dilatation with the balloon. And that's the final result. And then we went up and intervened on the cerebral circulation. So giving DAP during stroke intervention increases chances of symptomatic intracerebral bleed from 5 to 10%. So carotid stent is usually avoided in acute stroke stenting and done after 48 hours. If it is flow limiting lesion after POBA, you may stent the carotid even in the beginning of the procedure to secure the carotid access first and then perform cerebral intervention, and in that case you have to load with dual antiplatelet therapy. The other precaution would be if I put in a carotid stent first and then go up with a stent retriever in the cerebral circulation, then while I'm retrieving the stent retriever, it may get stuck into the carotid stent that's already deployed there. So then I have to take my guide catheter into the carotid stent and in fact above the distal edge of the carotid stent so that I capture the stent retriever into the guide before it gets entangled with the carotid stent. So that is something to remember. At times you get plaque prolapse within the stent, and the best way to visualize that is with an IVUS. So if you look at the carotid over here, and once the stenting is done, there is haziness in this region. This is within the stent. So an IVUS is showing a plaque prolapse over here. Now no matter what you do, if you do post dilatation within the stent, this will embolize and cause stroke. If you try to aspirate, this is plaque over there attached to the wall. You will not be able to aspirate it. So the best option for these plaque prolapses are to put in another stent within the stent and jail this plaque behind the second layer of stent. Now in this case, you can again see there is an accordion after deployment of the filter. So this is an area where the stent has been placed. This is carotid wall stent, and after post dilatation with 5 millimeter balloon, you can see stent well expanded here and here, but over here you can see the stent wall is outside and there is haziness within the stent, and contrast is not touching the stent wall. So if you look carefully again, this is the area where there is suspected plaque prolapse. So the only way to treat this is now put in a second layer of carotid wall stent within the stent so that this prolapsed plaque is jailed between the two stents. Now this is the case where you can see critical left internal carotid artery stenosis, spider FX 7 millimeter was placed, and then NC track 5 by 20 millimeter balloon was used for pre-dilatation, and after that protege 8 by 60 8 6 40 millimeter stent was deployed, and you can see again plaque prolapse within this stent. Now protege stent, as I mentioned earlier, has an open cell design. These are huge cell sizes, and this is an issue with protege, that you can get plaque prolapse. So what we did there in this case, we put a carotid wall stent, which is a closed cell design, within this protege stent, and jailed the prolapsed plaque between the two layers of stent. As you can see here, you can still see the haziness, but now this is behind the carotid wall stent, so the patient is safe from stroke. Now, this is a case with thanks from Gates Vascular Institute, Dr. Adnan Siddiqui. This is a right internal carotid artery. You can see a heavy calcification here. You can see the heavy calcification. So distal filter was deployed, and then 3 millimeter balloon was used for pre-dilatation in this case. Stent was deployed, and you can see there is a significant waste visible within the stent. Now, they were unable to dilate this waste with balloons. They were unable to cross this waste with filter retriever device to go and up and retrieve the filter. So patient became very agitated, had to be placed on mechanical ventilation. What they did, they pushed their guide right up to the waist, and from there they used a 5 French multipurpose catheter, diagnostic catheter, with a long balloon at the tip. The way balloon assisted guide liners are taken in inchworming, in the same way this multipurpose catheter was taken up, and it crossed the waist, and the filter was retrieved. After that, the patient was still on ventilator and developed stroke, hemiplegia on side, and CT angio showed that the stent really did not open up over here. Patient was immediately shifted to the OR and underwent successful carotid endarterectomy and stent explantation. So not every case should be accepted for carotid artery stenting, especially heavy calcification. What about the patients who undergo carotid endarterectomy and later on present with restenosis in the same lesion? So these patients are now going to be high surgical risk for repeat coronary and carotid endarterectomy because of risk of cranial nerve injury. And these are usually considered low risk for carotid stenting. Why they are considered low risk? Because of the internal carotid artery anatomy post endarterectomy. Typically, the loops that we see in the internal carotids are straightened out after surgery. Now the lesions are non-calcified, calcium is gone, and these are relatively larger diameter vessels because usually they get a vein patch, etc. The other benefit is these are now denervated carotid bulbs. So the requirement for atropine is also reduced. Now this is a 60-year-old lady who underwent right carotid endarterectomy 1 year ago, and now she presents again with TIA and raised carotid Doppler velocities, and you can see the restenosis in the area of endarterectomy, and this is treated in the usual way of distal filter, stent, and 5 millimeter balloon was used in this case. Unfortunately, few hours later the patient developed headache, and this is the CT picture showing hyperperfusion syndrome, intercerebral bleed. So luckily this patient did not develop any neurological sequelae and was managed conservatively and did well. But what's very important is that for all carotid interventions, the blood pressure post-intervention must be reduced to 130 by 80 or less, so that hyperperfusion syndrome can be avoided. This is a 70-year-old gentleman who presented with 4 hours history of left-sided hemiplegia, NIHSS 8, pre-stroke MRS 0, echo showing EF 35% with LV apical clot. Plain CT brain did not reveal any intracerebral bleed, and aspect score was 9. CT angio showed total occlusion of right ICA and MCA M1, IV bolus dose of TPA given, and TPA infusion started. Patient shifted to cath lab with ongoing TPA infusion. Now this is the head stabilizer that we use in the cath lab, and we are able to tilt the head whenever required. Pre-procedure examination on the cath table revealed a power of 0/5 in the left upper limb and 1/5 in the left lower limb. Local anesthesia given in the right groin and femoral puncture done under fluoroscopic guidance. Anesthesia team called for conscious sedation. 6 French femoral sheath inserted. We perform most of our carotid diagnostics with SIM2 catheter. So 5 French SIM2 diagnostic taken and diagnostic imaging done. Carotid angiogram confirmed right ICA occlusion. On RAO view, a small stump can be seen, but on the lateral view, it was difficult to judge the exact entry point of occlusion. 260 centimeter exchange wire taken and 6 French small femoral sheath exchanged for destination sheath 6 French 90 centimeter. At the time of this procedure, we were out of stock with the balloon tip guide catheter. Sophia plus 6 French with Rebar microcatheter and Trexus wire taken together as one unit through destination sheath. Sophia, destination sheath and Rebar microcatheter. All three were connected with Y connectors and they were connected with flush lines. As continuous flush is going on throughout this procedure, there is no heparin or antiplatelet on board. Sophia advanced up to the tip of destination sheath. Trexus wire with the help of Rebar microcatheter failed to cross the site of occlusion. So which wire should we use next? My next choice was a Fielder XT wire, but even Fielder XT wire could not cross the site of occlusion. So if you look at the injection again, so this contrast injection clearly shows that the proximal cap at the site of occlusion is really ambiguous. So my next choice was a Pilot 200 wire, and with the help of Rebar microcatheter, I finally succeeded in crossing the site of occlusion. So now the next question for me was, am I really in the true lumen or is the wire in the false lumen? So I advanced the Rebar microcatheter distally into the internal carotid artery, removed my Pilot 200 wire, and then took a 3 ml lower lock syringe with contrast, looked for back bleed, and once I confirmed that there was back bleed, then I took a careful injection with the 3 ml syringe, and that confirmed that I was in the true lumen. I then exchanged the Pilot 200 wire with the Trexus wire. I used 60 ml lower lock syringe with 20 ml plunger and a 3-way stopcock to create suction on Sophia Plus. I attempted to take Sophia Plus into internal carotid artery with ongoing suction on top of the Rebar and wire which were across into the ICA, but Sophia could not cross the site of occlusion, and as you would see now on the angiogram that it's taking a bend and is unable to cross. So then the next plan was I removed the microcatheter Rebar that was in, and through Sophia on the wire I took a 315 emerge balloon, but it could not exit Sophia Plus because Sophia Plus Y connector were 140 centimeter and the emerge balloon itself was also 140 centimeter. So the next plan was I removed the balloon, I removed the Y connector, and on top of the wire I just took the balloon alone in without the Y connector, and then I was able to take the balloon across and inflate the balloon at the site of occlusion. I decided to deal with MCF first, and over the deflating balloon I pushed Sophia Plus into the ICA and then advanced my wire, advanced Sophia deep into the internal carotid artery, and on top of this Sophia then I was able to push my 6 French destination sheath into the internal carotid artery and park it distally so that I don't lose my carotid access again. Next I prepared Sophia Plus for aspiration by putting the same 60 ml syringe with 20 ml plunger and a 3-way stopcock. Then I advanced my wire which has a loop at the distal end into the MCA And once it was there, then on top of the microcatheter, I advanced my Sophia into MCA M1, and at that time I also put my aspiration system on the 6 French destination sheath so that I don't lose any clot in the destination sheath. Now this is just to explain to you the setup. So 6 French destination sheath connected to a Y connector, which is again connected to a flush line which is continuously flushing. Then I've got a Sophia Plus in, which again has a Y connector and a second flush line, again has a continuous flush going on. Then I have a Rebar microcatheter which is again connected to a flush line through a Y connector. Through this I can take a stent retriever in if I want to, but in this case I'm just going to do adapt, which is aspiration only first. So these are the two aspiration systems that are connected. One is connected to the Sophia Plus, the other one is connected to destination sheath. So this is the UL system that you use in this procedure. So Sophia pulled out with ongoing suction, and good sized clots were taken out when we flushed Sophia, and we also aspirated the destination sheath so that we could take a contrast injection from there. So these are the clots that were taken out or removed from Sophia. So we were hopeful that we would have a good flow in cerebral circulation. So contrast injection from the 6 French destination sheath confirmed that we had good flow in the cerebral circulation with some spasm or ICAD seen in MCA M1 territory, and some slow flow seen in the carotids, which I thought was due to the spasm. So we rewired internal carotid artery with Trexus so that we don't lose the access, and then we pulled our destination sheath into the common carotid, and then this is what the injection revealed. So there is a tight stenosis here. So what to do next? So my concern was that cerebral circulation is patent and I didn't want any more distal embolization from the carotids. Unfortunately, I didn't have a cello guide at that time. I wasn't using it, a balloon tip guide, so no proximal protection. I didn't have a Spider FX Betronic filter which I could have taken on my Traxxas wire, which was 100% sure into the true lumen. I had to use a NAV6. So I took a NAV6, and while I was going to take it up, the next injection showed that the carotid by now was again 100% occluded, and it was slightly challenging to take NAV6 up. I was able to take it up, but I had my Traxxas wire in place. So I deployed this NAV6 into the straighter cervical segment of the internal carotid artery, and now I was ready for ballooning. I used a 4.5 millimeter balloon for pre-dilatation, and after pre-dilatation you can see that I had a no reflow. So why did I get a no reflow? What's the reason for that? Is it distal embolization that's taken place? Is the filter full of clots, or have I deployed the filter in a false lumen and all pre-dilatation has been done in false lumen? So what should I do next? I used a coronary thrombustor over the NAV6 wire for aspiration from the filter, but was unable to take it beyond the proximal marker of the filter. So then I removed it from the filter wire and I took it back on the Traxxas wire, and with that I was able to reach the filter and I aspirated as much as I could. After removing thrombustor, then I took the contrast injection, but unfortunately no flow persisted. So then my concern was if the NAV6 was actually in the true lumen. I decided to retrieve NAV6 and do the remaining procedure on my original Traxxas wire. So once the NAV6 was removed, I then took a contrast injection to see how things were after NAV6. But I could see a track going there, so there is still slow flow sort of a situation. So what should we do next? I decided to take a Casper, which is a closed cell design stent with a double mesh. But before that, through the NG tube, we gave the patient 600 milligrams of clopidogrel and 300 milligrams of aspirin as a loading dose. With Casper, it's important to ensure that the double mesh layer covers the whole plaque or the whole affected area, as we did in this case. So I'd taken a slightly longer Casper for this case, which was 8 by 30 millimeters in dimension. And after deployment of the stent, we saw that there was flow, but there was still slow flow post stenting. So the next thing I did was I again took my Sophia Plus up and aspirated through the stent and into the internal carotid, and then took it all the way into middle cerebral artery, and from there we did the whole aspiration process again. We did adapt, we did not use the stent retriever, and after we pulled the Sophia out with ongoing suction, we saw that we had good flow going into the carotid and into the cerebral circulation, although there was still an element of which I thought was more spasm as compared to anything else. I wanted to give Rapamil at this stage, but the patient's blood pressure was 70 by 30, so I did not give it. You can see the spasm here in the carotid. So at this stage, I would like to know what else should be done. Considering its spasm, we decided to stop. We did a groin check, used an Angioseal 6 French to secure the access site, and this is the immediately post procedure CT scan, which you can see there is no significant bleed or infarct on this scan.
हाँ जी, कैसी तबीयत है आपकी? अल्हम्दुलिल्लाह। बैठ जाएं जी, बैठ जाएं। अच्छा, बाजू उठा के दिखाएं ऊपर। बहुत बेहतर इंशाअल्लाह।